I'm very happy to officially start the webinar. I will start by introducing myself. My name is Pilar Hernández. I'm Managing Director here at the SORMAS Foundation. And today we will be talking about digital health, of course, gender, digital health, surveillance, disease surveillance, OneHealth, and SORMAS. So we will start with our first presenter that will highlight the perspective of gender in digital technologies. Then we'll follow with a presentation on gender in integration of gender's perspective in OneHealth initiatives, and then we'll finalize with showing a practical example of how to use SORMAS to design more gender sensitive and responsive and transformative disease control programs. So let me start introducing our first presenter, that is Patricia Mechael, Patty. For all of you, she's the CEO of Health Enable, where she serves as a technical lead for Global Digital Health Monitor. And she's also senior associate professor at the Johns Hopkins, where she serves as co-PI for the Digital Health Exemplar Study. She has nearly 30 years of experience advancing equitable and digital health and AI solutions across 45 plus countries with focus in gender intentional digital health and inclusive systems for maximized impact on the health outcomes. Of course, that was the short bio because we don't have more time today. But Patty, I'm very, very pleased that you accepted our invitation to be here. I'm very happy to hear your presentation. So the floor is yours. Again, as a reminder for everyone, if you have any questions that you want to ask Patty, please paste them in the chat and then we'll read them, collect them, and answer them at the end. Thank you very much. Over to you, Patty.
Wonderful. Thank you so much, Pilar. And I will never forget my first meeting of you at the Global Digital Health Forum in Washington, D.C. I think it was like 2 years ago. And it was during a session on gender intentional digital health. So it's really wonderful to be here and to talk a little bit about the state of digital health, of gender and digital health in 2025. And so really quickly, just to give a brief intro into how I got introduced into the digital health space. Early in my career, this was 1999, I was working in South Sudan. And at that time, I was there to help rehabilitate a primary health care center that had been destroyed during the civil war in Sudan. And one of the components of that primary health care center was a maternity ward, and we had a wonderful midwife, Miriam, who had been trained many years before and ran this maternity ward very, very beautifully. But one night at 2 a.m., I got a knock on my door, and it was the health center guard, and he handed me a note, and the note said, come quickly, difficult delivery. And it was a note from Miriam. And so I got into my Toyota Land Cruiser and drove over to the primary healthcare center, where there was a young woman who was 16. She was a complicated delivery of twins, and we really needed to get her, as quickly as possible to the one facility in the hospital in South Sudan that had an OBGYN. And in order to do that, we had, a two-way radio. The hospital had a two-way radio, and we could coordinate to make sure that the OBGYN was at the facility when we got there. It was a 5-hour drive, including a crossing of a river. And so you can imagine, access to health services and to, cesarean sections at that time, very, very difficult and challenging. And so that was sort of when I got introduced to the importance of transportation, communication in public health. And the delivery was successful. The mom and the babies were delivered safely. And then, unfortunately, 3 days later, we received the news that they all had passed because of poor infection control in the hospital. And so out of that experience, what I learned is that, technology and communication is really critical. Um, at the same time, they're only as good as the quality of care that is in the health system, that can support, people's health. And with that, I was inspired to do my PhD a year later on mobile phones and health. So fast forward, 25 plus years, 26 years later, and I am currently CEO at Health Enabled. We are a think do tank. We were founded in 2014, with a real focus on advancing sustainable country-led digital health transformation. So a lot of our work has really focused on national digital health strategies and policies, and many of the enablers of digital health. So evidence generation, as well as the Global Digital Health Monitor. And so, we've worked with a number of different partners, and at this point in more than 75 countries. And really our vision is around an equitable approach to health through digital technology and AI, really focused on whole person health, women and young people who are disproportionately disadvantaged in digital health ecosystems, and then technology in everyday life. So doing more on the digital determinants of health, which I'll talk about in a moment. We're a very diverse team, and we also have a very diverse global network of experts. And one of our big initiatives is the Global Digital Health Monitor and the State of Digital Health Report. A few years ago, we did a review and redesign of the monitor, and there was a real interest in including more on diversity, equity, and inclusion in the monitor. And so we added in an indicator on human rights and equity and inclusion, as well as a sub-indicator on gender. And so when we look at gender in digital health, what we find is that a lot of digital health strategies and governance do not include gender, that women are largely underrepresented at all levels in digital health leadership and activities. And then we've also, identified in parallel that women's mobile phone ownership is associated very strongly with greater digital transformation overall, and in health in particular. We're also seeing that there are new health risks that are generally not addressed in social or digital policies, like misinformation, disinformation, child safety, and technology facilitated violence against women. And again, these are areas that very much disproportionately impact women. And so if you're not taking a gender intentional approach to digital health, a lot of these things are being exacerbated and become a lot more prevalent and prolific. So just some of the ways in which, women's mobile phone ownership is associated with both maternal health outcomes and child health outcomes. A number of studies have been conducted in this area that really show across countries that when you have greater mobile penetration, and particularly women's mobile phone ownership, that you can see you know, associated effects, positive effects in, you know, child health and maternal health outcomes, including, you know, completion of immunization and childhood immunization. Um, what we have seen as well is that, you know, while there was some momentum to close the gender digital divide and increase women's mobile phone ownership, we've seen a stalling in closing the gender digital divide, and so there is still a relatively significant gap in women's mobile phone ownership, and with, you know, women being 17% less likely to own a smartphone than men, and 250 million fewer women than men who own a smartphone. What we also see is that women and other underrepresented populations lack visibility in data. And so there's a lot of gender bias, unfortunately, that we're seeing in the use of AI for things like recruitment, as well as in health. And you know, one clear example of this is in cardiology, where a lot of the ways in which you know, heart disease manifests itself in men is very different than how it manifests itself in women. And most of the research has been done in white males. And as a result of this, you know, women will go largely undetected for heart disease until it's often much more advanced than in men. And then, if you can imagine, you know, putting an AI model on top of that, a lot of the recommendations that then get made will then also further exacerbate and disadvantage women. We also see that women and other vulnerable populations are not well represented in technology fields. I had the good fortune of growing up with both a mom and a sister who were both computer programmer engineers. And so I didn't really fully appreciate or realize that there was this gender gap in technology development until I got into technology and health. And so we do see that many of the digital health technologies and interventions are often developed by men with very little representation of women, but they're meant to be used by women, particularly as frontline health workers, where women provide the bulk of health services in many of the countries in which we're working. And then we also see that women are, you know, underrepresented in global health leadership and in policy development. In some of the work that we've been doing with Gavi, the Vaccine Alliance, you know, they've taken a very strong gender intentional approach to immunization, and they wanted to apply the same, you know, gender intentional approach to digital health for immunization. And so, you know, we've done a series of reviews as well as studies in this area, you know, where we do see that gender dynamics in the workplace, digital literacy, you know, division of labor types of issues are having an effect on the overall ability to maximize the health impacts of digital health interventions. And so in, you know, implementations that do not take a gender intentional approach, we see a lower impact on immunization outcomes. In interventions that do take a gender intentional approach, we see a higher effect on immunization outcomes. And so, while we used to hypothesize that this was the case and this was actually happening, we now have you know, some results from research, from gender sensitive research studies, that are really demonstrating that this is what is actually happening. And so, as part of our work with Gavi, we developed this gender intentional digital health rapid guide that really strives to move us from, you know, being either gender blind or gender sensitive into having, you know, digital health interventions and enablers be much more gender transformative, that they actually promote equity, that they promote inclusion and diversity and greater accessibility and use for all users and stakeholders. And when you combine this with femtech and femtech approaches, which really favor, safety and privacy first, as part of design, and really account for the biological differences between men and women. You can then see a much more and better effect of digital technology in the health sector. We recently did a study in Ethiopia with the University of Gondar, and what we found is that there is this, when you look even just at basic representation, there is, very differential representation of females and males among caregivers, among community representatives, vaccinators, supervisors, digital health implementers, developers, 1% female, 99% male, and then policymakers. And so when you have this, a lot of times then you're not like taking into account the real needs and the real experiences of your sort of target users and your target populations. And so in this work, we saw this like really important need to implement activities that would help strengthen some of the gender sensitive foundations. So Ethiopia does have gender sensitive policies, but they're not necessarily operationalized. And then this real need to institutionalize this gender, responsive programming, as well as to invest in, gender transformative change. And one of the things to like really note is that this is social change. It is something that, often will take time, but it's really critical to see the extent to which you can kind of move things across a continuum, to move from being gender sensitive to being responsive, and then moving into being gender transformative. And so just to conclude, just a call to action, would really encourage in integrating gender analyses from the start of digital health design. You can't have gender intentional programming or equity unless you approach it intentionally from the outset. It doesn't happen, by itself. Technology is not equitable because you think it's going to be equitable. It's equitable because you decide you want it to be equitable and you design it that way from the very outset. We need to strengthen women's participation and leadership. Everything begins with representation. If people are not represented, their experiences and needs are not being included as part of the policy development, technology design, and or technology implementation. We need to invest in gender disaggregated data and research. Right now, in the age of AI, gender bias is very real. And a lot of misinformation, disinformation is designed and targets women and mothers in particular. And then you're sort of exponentially spreading a lot of this information by not taking a gender intentional approach and making sure that you are able to combat some of these challenges. And so with that, just want to thank Pilar and the SORMAS Foundation for having me. And please do reach out if you have any questions or are interested in this particular area of work.
Perfect. Thank you very much, Patty. I really enjoy your presentation, and I will just like keep the comment of being intentional. Maybe we can talk about this during our questions and answers section at the end. Now let me move to our next speaker. I'm very, very pleased to introduce Natalia Cediel Becerra. who is associate professor and researcher at the Universidad de La Salle in Colombia. She is veterinarian with OneHealth and OneHealth expert, of course, with 17 years of experience working with multidisciplinary health teams and intercultural workplaces. She serves as a public health consultant and advisor at national and regional level on OneHealth initiatives, and she's member of international panels and networks, including the OneHealth High-Level Expert Panel, OLEP, in short, for the quadripartite that many of you know, which is WHO, World Organization of Animal Health, FAO, and the United Nations of Environment Program. Natalia, thank you very much for, again, as well, for accepting our invitation to present here today. And the floor is yours. Over to you. We cannot hear you. Yes, there you go. The classical. Over to you.
Thank you, Pilar, for the invitation to present today in this important webinar. Actually, because today is the International Day for the Elimination of Violence Against Women. So what a better day to do this presentation and to do this webinar. Thank you to the SORMAS team and for people who are here. And also, thank you, Patty, for your inspiring presentation. That really, we really need to create this common ground to talk more about this. So I want to start first. Are you listening and seeing well, Pilar? Just to check the screen and my voice. Okay.
Yes.
So thank you. I wanted to start saying that we are in a special situation in the world, because even if we have gender equality recognized as a fundamental right, we have seen that in the specifically in 2024, the map regarding the advancements on the SDG 5, which is the one that speaks about gender equality and women empowerment, you can see that only few countries in the world has achieved the goals of this specific SDG. And many of the countries has challenge remain, significant challenge remain, and major challenge remain. So it means that we have not been intentional on gender equality, as Patty was explaining before. We need to be intentional to create this continuum from gender blind to gender transformative. Why is important nowadays? Because we have challenges, health challenges, as we notice in COVID. We have climate change and biodiversity loss crisis, where gender is part of the, not only of the problem, but part of the solution of those crises. And that's why we are increasingly and intentionally including the conversation between gender equality and OneHealth. So we believe that if we put at the center this SDG, the 5, we can create more advancement and yeah, we can go and do better with the other 16 Sustainable Development Goals. So how in OneHealth we are including gender equality? So in the last definition of OneHealth that we created in 2022 with the OLE panel, we not only wanted to be less anthropocentric and including the environment more clearly in the definition, the plants were included in the definition, but we knew from the experience in the last 20 years that we hadn't been able to include equity, access, better access, and more inclusion in the definition. So this time we wanted to do that better, and definition has 5 principles, and in these principles, equity, parity, and transdisciplinarity is part of the how we implement and operationalize the concept or the approach better. So how we recognize OneHealth actions, because we have equity among sectors and disciplines, but also we include society, and we are intentional in creating equity and better access. So that's why not only these 2 approaches, or as I normally teach, the gender equality or or gender approach is like putting some lens, like to see reality, how differentiated is reality for men and women. And when we put also OneHealth lens, it's because we wanted to include the whole perspective of reality, not only for human health, for animal health and environmental health. So why is this important? Because when we talk about gender responsive approaches, we will have better OneHealth outcomes. And also, when we have OneHealth interventions doing better, we will have progress towards gender equity. Why? Because gender roles influence not only exposure to risk, especially zoonotic diseases, but when we have gender roles, we have also some issues regarding access to resources, to land, to technologies, as Patty was saying, and especially the participation in decision making. So men and women, we have different zoonotic diseases risk, and we have also responses, different responses, because as I'm going to show some examples, we have different different roles in livestock care, different roles in food preparation, in hygiene activities at home, and also natural resources management are different between men and women. So how does this situation land in the OneHealth Joint Plan of Action? We, during the last 3-4 years, we have promoting this tool that is the Joint Plan of Action to be implemented at regional level and also at national level. And the quadripartite was really clear on saying that this Joint Plan of Action supports gender equity and women empowerment, because we know that at national level there are specific vulnerabilities that we need to address. But nevertheless, we have these tools, and we have a really intentional approach in gender equality definition of OneHealth. We haven't seen reflected this intention in all the action tracks of the Joint Plan of Action. Only the action track 2 and the action track 5 that speaks about the zoonotic emergence, zoonotic disease emergence and pandemics, and the 5, which is about the MAR, the antimicrobial resistance. Only these 2 has intentional indicators on gender. The others are lacking this view. This can be solved. Obviously, this document is not written in stone. It's a living document, but that's why we need to talk more about this. And in the OLEP panel, we are doing some progress in integrating this lens, the gender lens, in the Joint Plan of Action more clearly. We also, last year, we had a OneHealth tools inventory, and during the analysis of those tools, we reviewed 50 tools of OneHealth from the quadripartite. We noticed that not all of the tools have included gender lens or gender analysis specifically in their tools. Only 4 of the 50 tools were included. So now we are working on that in this panel, in the current panel, and I hope to show you in some months the publication regarding that integration. As Patty was explaining before, we have a gender continuum framework that we notice that if we are having, for example, a OneHealth project, OneHealth program or policy, we cannot continue being gender blind. What does it mean? Because if we ignore the roles, the rights, the responsibilities and the obligations associated with being female or male in that cultural context, we are going to be gender blind, and we will probably lose the possibility to address some of the power dynamics that are in place in this context. So what we are promoting each day more, I'm noticing that since 2021 and to today until now, we have a growing body of evidence published regarding the importance of including gender equality in One Health. And we have this chapter 9 in the book that I recommend you, Principles of One Health for a Better Planet, that we state that we need to go from gender blind to gender transformative. What does it mean? That we need to address inequalities, but also we need to be clear on the goals that one of the goals to support better human, animal, and environmental health needs to address those disparities and need to create more gender and dynamics, more equitable. So yes, we need a change in mindset, but also we need to know what to measure, how to measure, who we are measuring in the context, what it is the meaning of the data collected, and the purpose of our interventions. I wanted to highlight 2 examples. We have doing a review in the current panel regarding the community engagement and participation, and we noticed that we need to include clearly the gender sensitive approaches in One Health. And we have doing the research, and I noticed this paper speaks clearly on the barriers. They did a systematic review in Africa and Asia regarding livestock vaccination, regarding the barriers for livestock vaccination. And they noticed that there were 3 domains that influence how people can improve the vaccination campaigns. And they understood that perceptions, access, and roles really influence how. For example, in the perceptions, they understood that there is a distrust in vaccine due to the past experience regarding vaccine delays or concern about the cold chain of vaccines. But women were more likely to reject or reduce their involvement in vaccination if they believe they will result in men controlling their income. So that's especially, we know that we need to include this gender analysis if we want to succeed in vaccination campaigns. Regarding to access, the study understood or highlight that women's vaccine access was hindered by cost and mobility. They were not easily it's not easy for them to take decision to go and vaccinate their animals because of the cost of the vaccines and also because of the cost of traveling to get to those campaigns. There are also some women often lack decision-making power. What does it mean? That probably those decisions about the health of animals are more based with men in the families or in the community, and probably the larger herds are prioritized by men's access. So that's why it's important. And regarding their roles, I wanted to mention that women manage a smaller livestock, for example, poultry and small ruminants, and that actually allow them to integrate their household or their domestic activities in their daily lives. So that can create limited time to participate in vaccination campaigns. And there's also a cultural belief that that can restrict women's livestock roles. So the main outcome of this research that I wanted to highlight is that one size fits all approach is probably not going to succeed in vaccination campaigns. We cannot create a formula that applies to all contexts. We need to understand each context specifically and address these gender norms, the social and cultural aspects of how they relate to health, to preventive actions and measures. And there's another paper that was released this year from the Women for One Health. The network, they have a recommendation paper to advance gender inclusion in One Health, and I wanted to share it with you. I want to to highlight the second one, that is to collect and use gender disaggregated data and indicators. We noticed that for climate change adaptation and also for disease prevention, we need those indicators. And if we don't collect data differentiated between men and women, it's going to be hard to find those indicators. And also not only for monitor programs, but also to promote women leadership and career development in OneHealth fields. We noticed that there is a paradigm that we need to also shift from, not only going from parity, that is 50-50, 50 men, 50 women, but also to create more leadership, women leadership in this field. And one of the main examples of the importance of gender equality in OneHealth is that we need to empower women in community-based implementation, as, for example, Patty was explaining on maternal health care, because they have a recognized role of leadership in their communities regarding taking care of animals, but also the natural resource conservation. And the last paper that I wanted to share with you is a paper that was published on Friday, and that is regarding a guide that we call Gender Responsive and Inclusive Implementation Guide for National OneHealth Action Plans. If your country is interested in integrating this approach in the OneHealth Action Plan, we are proposing 32 yes/no questions. It's very friendly to use. Regarding the 5 steps in the OneHealth Action Plan. We have, for example, I'm not going to present the 32 questions, but I just wanted to acknowledge the importance of this intention to do this. No, in the step 1, situation analysis, a potential question that we can ask ourselves or the governments is if there is an intersectional gender analysis conducted as part of the situational analysis. If we don't put the lens to see the reality, we are not going to see what is happening between men and women in reality in the communities. In the step 2, that is creating or strengthening a multi-sectoral OneHealth coordination mechanism, we notice that an important question that we need to acknowledge is if there is a technical advisory function for gender and inclusion. Normally, people think that that we don't need an advisory group to advise the government. It's important that we recognize that expertise and that we include it. The planning for implementation step, there is an important question that I think is key, that are there strategic objectives and criteria aligned with the addressing gender and social inequities? In a country, for example, like Colombia, that this is the second most unequal country in the world, we really need to have strategic objectives addressing those inequalities. If we don't include them as an objective, it's probably that our OneHealth actions are not going to fulfill the needs of the people that are most at need or at most at risk. In the step 4, the implementation of national OneHealth action plans. This is huge. There are a lot of questions here in this step 4, but I want to highlight the importance of training. Have the committee members or implementers been provided with gender equity and inclusion training? We need training to do this because as you notice, there are many things that we need to have in mind and to respond in a different way. And in step 5, we have this monitor and evaluation part. And the question that we recommend, or that I'm noticing that I select, is, do OneHealth implementation accountability mechanisms include accountability for the gender equity and social inclusion? So if we don't do these questions, if you read all the papers that has been published in the last years, they recommend to make good questions. So my good questions to provide a specific study of the needs in the specific local context. So the takeaway message, these are pictures of different parts of the world. Women are really in a position of leadership, but we really need to be intentional on that. In OneHealth policies, tools, and framework, this approach has been neglected, and we really need to go a step, give one step in front of these needs. Gender roles and gender norms and dynamics influence the ability to implement OneHealth joint plan of action. So we need to transform these norms and dynamics slowly, or really not slowly. Really, we are needing more and more intention on that. And gender transformative policies and programs are needed with indicators and clear budget. And finally, the approaches that don't account for these gender dimensions risk missing critical points of disease emergence and community vulnerability. So thank you very much. I hope that if you have questions, I can be able to answer here or by email if you want. Thank you.
Thank you very much, Natalia. Very, very, very interesting. I'll go now and introduce our next speaker. Our next speaker is Christin Walter. Christin Walter, she must be one of the people that has been working with SORMAS the longest. She has been working with SORMAS for the past 7 years, with a special focus on the use of SORMAS in Germany during the COVID-19 pandemic. And she's currently project manager at the SORMAS Foundation and has been responsible for the development of the gender and surveillance course at the SORMAS Academy that she will be presenting today. In the frame of the GIZ Global Program for Pandemic Resilience and OneHealth, funded by the German Federal Ministry for Economic Cooperation and Development. So the idea of developing this course that she will present is to show a practical example of how to use digital tools, digital technologies, as Patty has presented, to design more gender-sensitive, transformative disease control programs. Christine, over to you. The floor is yours.
Yeah, thank you very much, Pilar. So I will quickly share my screen and directly jump into the SORMAS Academy. I hope you can see my screen now. My colleagues will also post the link to the SORMAS Academy again in the chat. So the SORMAS Academy is a training program where you can log in and also collect a few points until the end to also get a certificate, but you can also do it without. So if you log in, you have different courses. At another webinar, we presented already the basic course. Today, we will go through the gender and surveillance course. So if you log in and if you select the English language, you have the introduction to the gender and surveillance course. I will go through it with you together. When you scroll down, you have a few informations regarding the course, how long the course probably takes, that you can get a certificate at the end when you create an account for it, which is free of charge. You have different learning objectives from the course. Yes, and what we do is, for example, you can start with a quick quiz regarding the SORMAS basic course, because we always advise to go through the SORMAS basic course first, and then you can continue with different chapters and different courses. So this is like a backup regarding the basic course, and then you can start with the SORMAS gender and surveillance course. You can do it step by step. And what we really recommend is that you go through the WHO course regarding gender first, And then you also have a quick quiz here. If you click on that, you have different questions. You can go through it, you can answer them, and so you see if your knowledge is quite good to continue here with this course, because we only start with a few general information and the understanding regarding, for example, sex and gender, the differences, and we also explain why sex and gender matters in surveillance. So you go there step by step. And after every section, you have a quiz where you can either click through it, like here, for example, we have a gender, it's called true and false quiz. I will quickly show you how it looks like. You get different questions. I will show you. You have, for example, the question sex and gender mean the same thing. Then you decide for your answer. And then you check, or you directly continue and get the result at the end. And then you get another question. Then you click true or false. You can also always check and see if the answer was correct or incorrect. And then you can go through the whole quiz to also, yeah, make it a little bit interactive. Besides that, after every quiz, so for the quiz, you can reach out different, like we call it stars. You see it here on the top as well. The star will be collected at the end, and you need a few points to get the certificate at the end, which can be then downloaded at the end. Yeah, when you go through it, you can do it step by step. You can always check your knowledge. Here, for example, is another type of a quiz. Here you have to drag and drop the correct answer you think. If it is related to sex or related to gender, you just drag and drop it into the fields. Whatever you think is correct or incorrect, you can also remove them if you have to think about that. Yeah, just to get an overview. And what we have then at the end, or the next chapter, are always the use cases of SORMAS. So when you dive into this section, you have the different use cases. And if you go through the different use cases, I will click on that now. You should be able to see them. For example, the first use case is the pregnancy, vaccination, and surveillance. You always have a short explanation regarding the scenario and also regarding gender considerations and the recommended strategy. So you go through every use case like step by step. And then when you scroll down, you always see the parts in SORMAS and how it's structured in SORMAS. Here it's important that on the right side you have the gray button. You have to slide it a bit down to see the different steps. So on the one hand, you can also navigate to the SORMAS demo system to click step by step, or you just see the screenshots with the explanation first, and then you can try. That's, yeah, you can decide whatever is better for you, whatever you prefer, and then you do it step by step. For example, here, second step, click on the case ID you want to edit. Then you open the case, and then you can define the case classification. Then on the next step, you can decide, for example, regarding the additional medical information, if the patient is pregnant or not. And then you can enter more details regarding the potential pregnancy. And this will be shown like here, step by step. You can then include the vaccination status. I will just quickly go through it, but of course you can do it in detail, step by step. And for this is for every use case the case. You always have an explanation on top, a screenshot with a red dot where you see where to click. So we really recommend and invite you to go through the SORMAS demo system and try it yourself. Important to mention here is that the demo system is available on the website. We can also post the link in the chat again. It's a demo system, so we really invite you not to include real data. You can play around with it, but please use, of course, fake data. Yeah, this is the use case 1. We also have use case 2, where you, for example, have the background healthcare workers and gendered risks. Then we have another use case regarding women as caregivers and household responsibilities. So in total, we have, as you can see on the left side in the menu, we have in total 5 different use cases. And at the end of all the use cases, you also have a quiz you can go through. And after it, you go through the SORMAS gender strategy. You get a few insights regarding the SORMAS strategy. What does it mean? Where can I get all the information? And here at the end, you have the summary, where you then reach the end of the course. And if you scroll down here, you can also see your course evaluation. Let me switch off my edit mode. So you can also see how many stars or benefits you reach. You can at the end, if you reached all the points you need, you can create a certificate and you can see it there, whatever you prefer. So I really recommend you to log in with your account so that you can also keep track of your success. And I think these are the most important points. I don't want to go too deep into the system, but please reach out to us if you have any further questions to the SORMAS Academy in general, or also to the new gender and surveillance course. And I think from here I will stop and give it back to Pilar and open for questions. Thank you very much.
Thank you very much, Christine, for this overview of the course at the SORMAS Academy. Now we are going to start our question and answers part of the webinar. We have a question from Tara. Thank you very much for the fantastic presentations. The question is, what are some of the main barriers preventing countries from fully institutionalizing gender-responsive programming and investing in long-term gender transformative change? So Tara, I'm not sure to whom you're asking the question, but I guess the question goes to both. So whoever wants to start, Patty or Natalia, please feel free. What are the main barriers preventing countries from fully institutionalizing gender responsive programming and investing in long-term gender transformative change? To any of you.
I mean, I think the thing that we see is that, without strong female leadership in different positions, gender does not magically happen, right? So, and if people are not experiencing the power dynamics themselves, they're not likely to take action, to address them. And then there's also, misaligned incentives. There's a lot of power dynamics and reasons why people would like to see, themselves advancing while others, not advancing. So, I mean, I think we definitely need to promote more women in leadership roles so that they can take on some of these issues that disproportionately impact women and children. I mean, I think we also don't see a lot of work happening on children, and that is a shame.
Thank you, Patty. I agree with that. And besides that, I noticed, and we have been noticing this year, that the lack of, in terms of the OneHealth approach, there is not scientific evidence that we can push, on the interface, the human, animal, environmental interface. There are studies on human health or animal health, but not in the whole spectrum of the integrated health. So that's why the panel this year is doing our best to do the policy brief, integrating the studies that are available, and also promoting research on this, on creating how this approach, gender equality and the gender transformative approaches are providing better outcomes in the whole in the interface of human, animal, and environmental interface. When we have this evidence, another barrier is to translate the research into clear words for policy making people, or to translate them, their good results, in actions that that the government can use and integrate. That's what we have seen, but also the cultural shift that we need to do in support of the women leadership, but also how to translate the science into policy actions.
Thank you very much. So I think we don't have much time for questions, but maybe just like some quick question for you both. So I took some of the key, some keywords that you mentioned. The one is, of course, intentional. I think, Patty, you mentioned that at the beginning. We need to be intentional. And Natalia, you mentioned the lenses, right? The lenses on OneHealth, but of course the lenses of gender. And then again, in the current circumstances with all the changes at the national level. So my question to you, and I agree, we don't have much time, but like how, and I know you have given like action, a call to action and examples and so on, but if we want to be intentional with our gender lenses in the current situation, like what is like one of the easiest things to do? Like, for example, in SORMAS, so what would be your recommendations to SORMAS or to anyone in the audience, like that it's so that they don't find an excuse to say we don't have funding, we don't have this, we don't have that? Because I think we shouldn't be looking for excuses. So what do you think?
I mean, I would say the first thing would be to do like rapid gender analysis, understand where your starting point is. Like when we did the gender analysis in Ethiopia, I mean, it was like, it took us very little time to do it. And it uncovered so much. It uncovered the strengths that they had in terms of, some of their affirmative action policies and gender units. It also identified some of the major weaknesses and gaps in terms of representation. And so, I think that is like a really easy way to kind of get a sense of just visibility into like, where are you right now? And then thinking strategically about where you might want to like take one or two areas and try to like take action to address them.
Thank you for the question, Pilar. I think what SORMAS is already doing it is creating this course, this online course available for everyone, because training is part of the problem, no? That people think that is gender analysis is something really, really, really super hard, but it's what you have available, that the course that this course is available for everyone in a country is part of the solution. I think you are already doing the gender lens, not doing a step forward on the solution. So I think it's a matter of governments and institutions to take this course and to continue the improvement of going from blind, exploitative, adaptive, and then transformative. So I'm very happy that you are doing this and that you are supporting countries to put the lens.
Thank you very much. With that, we will need to conclude our webinar. I could spend hours and hours, really. Thank you very much for the fantastic presentations. I hope everyone enjoyed as much as I did. Again, if you have any questions to us or to Natalia or to Patty, do not hesitate to get in touch at our info@sormas.org email address. Maybe my colleagues will post it now in the chat. I wish you a wonderful day ahead, evening ahead, or afternoon ahead, wherever you are. And thank you very much for being here. Again, if you want to watch it again, watch the webinar again, you can find it in our YouTube channel. Have a lovely day, afternoon, or evening ahead. Bye-bye, and to the next one.